friends and colleagues, we at WBAE have been trying to organize training programs so that the standards of echo evaluation across all laboratories follow the same protocol. My talk is on aortic valve disease, and the exercise is particularly aimed at the fact that recent times there's been recent advances in management of aortic valve diseases. Both percutaneous and surgical AVRs have been done. So with that in mind, we need to have accurate data so that we can choose our patients correctly and uh, get the right morphology of the aortic valve to aid in the management of the patients. So before we start, there are certain basic things that I would like to highlight. One is we must have an ECG connected to the patient for all our cases, and then enter the height, weight, and blood pressure, because blood pressure is very important when we are doing a hemodynamic evaluation. So, and we do a brief clinical examination before we start the uh, testing. The first case.
Hello, friends. I'm going to share with you a few cases of echocardiography in aortic valve disease. As we all know that there have been recent advances in percutaneous and surgical interventions in aortic valve disease, and it has become imperative that we learn how to accurately define the morphology, assess the hemodynamics, and evaluate the left ventricular function for these cases before intervention. Before commencing any study, we need to have a clinical background of the patient, do a clinical examination, look at the ECG, X-ray, take the blood pressure, enter it in the patient data, take the height and weight, and also connect the ECG cables before commencing the study. So, as in any study, we start with the parasternal long axis view to give us an idea of the chamber dimensions, the left ventricular function, the wall thickness of the left ventricle, the aortic size, and the aortic and mitral valve. In this case, the aortic valve appears thickened, not very calcified, but shows restricted opening. Perhaps the most difficult aspect of evaluating the aortic valve area by the continuity equation is assessing the left ventricular outflow tract area. So the recommendations are to measure the LVOT dimension by zooming in into the LVOT and take the measurement just below the aortic valve leaflets and avoid any calcifications. And then this diameter is used to calculate a circle area. However, we know now that the LVOT is usually not a circle but an ellipse with the anteroposterior diameter less than the medial to lateral diameter. So we can use the X-plane imaging to actually planimeter the LVOT area, but we have to do it very carefully so that we are doing it just at the level where we are going to place the pulsed wave Doppler sample volume to assess the stroke volume. Next, we zoom in on the aortic valve to look at the morphology. This is a bicuspid valve with a raphe posteriorly. The fused cusps are of the left coronary and the non-coronary cusps, and there is an elliptical orifice, which is the hallmark of a bicuspid valve. You can observe the calcification on the raphe and modest calcification of the cusp margins. Next, we move on to the mandatory measurements of the aorta and the aortic valve. These are done in a zoomed view. The LVOT measurement was taken in systole earlier. Now we take the measurement of the aortic valve, again in systole, and then freeze it in diastole, preferably end diastole, to measure the aorta at the level of the sinuses and at the level of the sinutubular junction and of the ascending aorta. Now we take a look at the short axis of the left ventricle to see the left ventricular systolic function and wall motion abnormality, and then a short axis at the level of the aortic valve to look at the aortic valve stenotic orifice and the jet that is passing through the stenotic orifice. So next we take a look at the apical long axis and the apical 5-chamber view to take a look at the stenotic jet and align it so that we get a good CW Doppler spectral tracing to measure the peak velocity across the aortic valve and the mean gradient across the aortic valve. The LVOT velocity is recorded with the PW Doppler from the apical approach, either from the apical 5-chamber view or from the apical long axis view. The sample volume is positioned just proximal to the aortic valve. It should be optimally positioned so that a smooth velocity curve with a well-defined peak and narrow band of velocities throughout systole. It should not be very close to the stenotic aortic valve to avoid spectral dispersion, which happens near the valve. We can just pull it back a little towards the apex to get a clear signal. Then we measure the spectral tracing to get the mean and the peak, mean VTI of the LVOT gradient. In order to take the highest velocity, we need to use multiple acoustic windows to get the highest jet across the aortic valve. Here we are using the subcostal view, but evidently the jet is not aligned with the transducer. Next, we take a look at the right upper parasternal view with the patient in right lateral position. We try to get a hold of the jet and see if it's greater than the one we've seen in the apical 4-chamber view. We can also look at the jet from the suprasternal view, look at the arch, and look for any coarctation if present. Ideally, a dedicated small dual crystal CW transducer, also called the pencil or the Pedoff probe, is used for these velocities which are taken from the suprasternal or the right parasternal view. And finally, before completing our study, we look at the left ventricular function, wall motion abnormalities, and also the global longitudinal strain, and then look at the diastolic function, look at left ventricular pressures and the right ventricular pressures before we conclude the study. Looking at the PW flow pattern of the mitral valve, it shows a grade 1 diastolic dysfunction with normal left atrial pressures. We take a look at the right ventricular pressures by measuring the tricuspid regurgitation gradient. And finally, we measure the IVC in inspiration and expiration to get an idea of the right atrial pressures before concluding the study. So in conclusion, this was a 64-year-old lady who presented with shortness of breath on exertion with no history of chest pain or syncope. She did not have a history of hypertension, diabetes, kidney disease, or anemia. On auscultation, there was an ejection systolic murmur in the aortic area. ECG and chest X-ray suggested left ventricular hypertrophy. Her transthoracic echocardiography shows a thickened, mildly calcified bicuspid aortic valve with fusion of the left and non-coronary cusps and calcific raphe posteriorly, resulting in an elliptical stenotic orifice. The mean transaortic gradient was 42 millimeters mercury, and the peak transaortic velocity was 4 meters per second. The DVI was 0.20. The calculated aortic valve area was 0.5 centimeter square, and there was no significant aortic regurgitation. She had left ventricular hypertrophy with normal left ventricular systolic function and grade 1 diastolic dysfunction. The other valves were normal. There was no evidence of pulmonary hypertension. Effacement of the sinotubular junction was noted. The ascending aorta was dilated on indexed value, and there was no coarctation of the. Moving on to another case. Here there is a dilated left ventricle with poor LV systolic function, and there is a central regurgitation jet of aortic regurgitation. So here we can see a central jet of a moderate AR. The jet width and the LVOT width can be compared. Here it is 35%. We can also take a look at the RP half time which between 200 and 500 suggests moderate AR. You need to have a good spectral tracing for that. You can also measure the VTI of the AR, and combining with the PISA radius, we find out the regurgitant volume and EROA of the AR. Next, we go up to the suprasternal view, look at the aortic size, and also look at the flow within the aorta, whether there is flow reversal. We do a pulse wave Doppler study to see any flow reversal. If there is holodiastolic flow reversal, it suggests at least a moderate or severe AR. Just to demonstrate how to measure vena contracta of aortic regurgitation, I've chosen a case of rheumatic heart disease with both valve disease. Here there is mitral valve involvement with mitral stenosis and aortic valve involvement with a moderate AR. Now we need to zoom in on the left ventricular outflow tract and get a good color Doppler tracing to visualize the regurgitation jet. And we identify the narrowest portion of the jet, which occurs just downstream from the flow convergence zone. Now, when we measure the narrowest portion, if it is less than 3.3 centimeters, that is 3 millimeters, it's a mild aortic regurgitation. And if it is more than 6 millimeters thickness, then it's a severe aortic regurgitation. Moving on to another case of aortic stenosis. Here we can see a stenosed aortic valve with minimal movement in systole. There is calcification on the right coronary cusp. There is also aortic regurgitation, which appears mild. There is mild mitral regurgitation. The left atrium appears enlarged, and the left ventricular function also appears depressed. We shall see later on. So we do our usual measurements, measure the aortic annulus in systole, we measure the aortic LVOT dimension in systole, and then go on to measuring the aortic diameters in diastole at the level of the sinus, at the ST junction level, and at the level of the aorta. These are mandatory measurements that are required for future use. Now, having made those measurements, we can also do the same thing that we did in the earlier case. We can try a biplane method where we measure the area of the LVOT by planimetry. The results of the continuity equation with planimetry is usually slightly larger than with LVOT dimension only. So here the LVOT area by planimetry is 4 centimeters square, whereas the LVOT diameter is 2 centimeters, which comes to 3.14 centimeters square. Here the short axis of the left ventricle showed reduced left ventricular function. Zeroing in on the aortic valve, the short axis of the aortic valve shows another bicuspid aortic valve with a raphe anteriorly. Here we can actually planimeter the aortic valve area, and that has come to 0.8 centimeters square. Next, we move on to continuity equation. We measure the LVOT spectral tracing. So we get the LVOT VTI, the same way that we saw earlier, and we go on to measuring the CW, the continuous wave Doppler measurement of the aortic valve to get the aortic valve area. Usually more than 3 readings are required for averaging. The machine sometimes does the spectral tracing. We can do it manually also. So you notice that though the aortic valve appears severely stenosed, the maximum velocity is far less than in the previous case. It's 3 meters per second, and the mean gradient is about 24 or 25 millimeters mercury. Whereas when we use the continuity equation with these same measurements, the aortic valve area came to 0.8 centimeters square, which appears to be severe. So this is a case of severe aortic regurgitation, aortic stenosis with low flow and low gradient. So while completing the case, we found that the patient was in heart failure, the IVC was distended, there was pleural effusion and pericardial effusion. So this case actually brings out the discordance between the aortic valve stenosis, which appears severely stenosed, whereas the pressure gradients do not match up with the severity. This happens when the left ventricular function is less and the stroke volume is less than 35 ml per meter square. So we have to be aware that we just cannot go with the gradients. We have to take into consideration that the left ventricular stroke volume determines the pressure gradients, and even sometimes when there is normal ejection fraction with a small LV cavity, we can have smaller stroke volumes which reduce the pressure gradients across the aortic valve. So these are considerations that must be kept in mind.
So to summarize, we need to follow the protocols that have been set up by AAC, and it is important that we are all on the same page so that the reporting is uniform and it helps in surgical decision making.